Welcome to Week 12, Clinical Documentation Improvement Principles and Practices, Evaluating Success. And this week we're going to talk about how you evaluate on an ongoing basis the success of all of the things that you've put into place. We've talked about selecting and training CDI staff, training each of the different interested persons within the hospital, including the medical staff. We've talked about the metrics that you use to guide your program. And so once you have your program up and running, after all of that, you might think that you're good to go. But in actuality, a CDI program takes a fair amount of ongoing maintenance, if you will, to keep it pertinent, to keep it current, and to help it have ongoing success. So we talked a little bit also about the goals or the performance indicators for your program. How do you demonstrate to your administrative group that your program is valuable and that it's earning its own way? A CDI program is not, every hospital doesn't have to have CDI. They can choose or not choose. So it's not like nursing or any of those other very key roles. They can choose to have a CDI program or not. And often it will come down to what are the benefits of this and how do we return our investment on this particular program. So when you establish a CDI program, you have to have very clear indicators for what your program is going to gain the facility and how it's going to perform. And these are usually developed based on the goals for the CDI program. Every facility will have its own goals for a CDI program. The overreaching goal for CDI is a accurate, precise, and complete medical record, right? That's what the role of CDI is all about. However, each facility has a reason why they brought in the CDI program. Why are they investing in the CDI program? It could be for some facilities that it's still more financially driven. Maybe they feel like their case mix is just lower than what they know their patient population should be generating. So they really want to bring in CDI to say, let's improve our case mix. Let's make sure that our charts are coded to the most case mix that we can recoup. It could be that there are quality issues, and that's why they want to bring in CDI. So whatever focus your facility had or whatever reason they had for bringing in a CDI program, that's going to drive your goals, right? So if they're looking to see that case mix come up, a lot of your goals are going to be focused in that area. If they're looking to see the risk of mortality more accurately reflected or the quality and the core measures to improve, that's where some of your metrics and KPIs are going to be. So it really depends on why they created the program in the first place. And I cannot say this enough. If you go to work for a facility and they cannot clearly state to you why they have a CDI program, it is going to be much more difficult for you to prove your success and to prove your worth. And I have experienced this, and that's why I say it. So that's a good question to ask when you're interviewing. Why do you have a CDI program? What are the goals of your CDI program? Because that's really important to the whole structure of the program. The role doesn't change so much facility to facility. You're looking to identify those gaps, query and fill those gaps. That kind of process stays the same, but your performance evaluation is really going to depend, on why that facility is developing that program. So there's lots of different ways you can measure success. and you can be measured. We've talked about this when we went over metrics, right? You can measure against benchmarks, local benchmarks, regional, national. You can benchmark against yourself. If they say our surgical case mix is low and we know our surgical patients should have a higher case mix, then you get that baseline. And once you've implemented your program, you benchmark against that periodically. And that's how you evaluate your performance and your improvement, right? So you establish those goals, and then you can prove your worth, if you will, or the return on investment, as we said. So you do have to look at the variables within your program when you decide how quickly you want to reach goals and how quickly you want to reach, whether they be interim or long-term. You have to look at the number of staff that you have. So maybe you really need 5 CDIs, but administration's only willing to pay for 3. They want to see what you can do with 3. So you really need to use your data to focus and prioritize your reviews. If you're interested in surgical case mix and you only have a certain amount of, if your focus is case mix, let's say, and they say, well, these are the 5 service lines we want to look at, then you start with the most impactful one, which usually is surgery. And you focus your efforts there, and you'll be able to show a good improvement, and then that may open up staffing for you to expand into all of the areas that they want to cover. So you use your data to prioritize your reviews, put your staff where it's most impactful, and that way when it comes time to evaluate, you can see how you are meeting your goals and meeting the definition of why your program was started at that facility. A lot of facilities, because CDI is not mandated, they do want the program to pay for itself. And so that's something that you have to be aware of. You have to make sure that you're being making the most impact that you can, that you are identifying the populations that have the most potential for growth, right? And that's where you're focusing your efforts first before you move on to other groups. All right, so you have a need to prove your success. So as a CDI manager, how do you do that? You can look at the case mix, both pre and post CDI intervention. And you can justify or evaluate your return on investment based on that across your facility. You can look at all payers. You can look at specific payers depending on what your facility wants you to focus on. And this is one area, case mix is one area, again, where you can compare to your baseline, but you can also compare to benchmarking nationwide, because similar hospitals with similar patient populations, then you know your case mix should be in that ballpark. Another way that you can demonstrate ROI is on your CC-MCC capture rate if you're in the MSDRG area. And so for each diagnosis, or each DRG, I should say, you evaluate based on, again, benchmarking against peers, you can benchmark initially against your baseline, but you will move on from that. So this is where the primary diagnosis is very important, right? And then all of those secondaries are very important. So that's another way that you can document and demonstrate your return on investment. Another way is based on that primary diagnosis assignment. So I use pneumonia a lot, but there are benchmarks out there that will tell you your peer organizations what is the percentage of their pneumonias that are simple, and what is the percentage that they're able to move into the complex pneumonia DRG. And let's say that your peer, even within your state, you can get these reports for within your state. So let's get very close to home then and say a hospital that I know in my area who has a very similar patient population, only 30% of their pneumonias are in the simple pneumonia DRG, whereas 70% are in the complex, because often pneumonia is not, if it's simple, it may or may not be admitted to the hospital. So 70% of the admissions are in the complex pneumonia category, or DRG. Well, I don't have that. I have the exact reverse. I have 30% being in the complex and 70% being in the simple. Then you know, based on that benchmark data, you have some work to do. Because if you have a similar patient population and they are moving that, so then what do you do with that? As a manager, you're going to look at that. You're going to look at how well does my staff understand. First of all, how well are we covering that patient population? Are we in the med-surg unit where those patients are? How well are we covering that patient population? And then beyond that, does my staff understand what's needed in documentation to take a patient from the simple pneumonia DRG to the complex pneumonia DRG? And if they understand that, are they able to recognize the treatment and the evidence that this patient should be in that complex pneumonia DRG? So those are all things. Then you would pull some charts, you'd run an audit, and you'd see who on my staff understands this process and who seems to not understand this process, right? And then you watch that, you roll out some education, and you see what happens in the next 30 or 60 days or quarter, whatever time frame you choose. And that's how you know if you're moving that KPI, if you will, if you're having an impact there. Procedures are another area that really impact. If you're accurately capturing and coding procedures, it will really impact your case mix. And that's an area that you need to focus on if your surgical case mix is at all low. Not only the CCs and the MCCs, but are those procedures being captured appropriately? So that's a couple of ways that you can look at your case mix index as a return on investment KPI. Another thing that you might want to look at are the number and percentages of admissions that you're able to review. So when I came to the facility that I'm at, they said CDI is only looking at 60% of the admissions. And we feel like they should be looking at closer to 90% of the admissions. Well, it's a very large facility, and they have 3 clinical documentation improvement nurses. And when we looked at what their daily productivity should be and what the daily admissions were, we had a horrible mismatch, right? So what we had to do was this very process of where's our focus going to be? Where are we the most impactful? And let's put these 3 nurses where they're going to have the most impact. And then if we begin to show a very aggressive movement and improvement, 1, they're going to be happy with that, or 2, they're going to say, oh my gosh, we need a couple more bodies, because if we can show this kind of improvement, then we need to expand this program and cover all patient populations. So that's another way that you can look at proving, I guess, the validity of the role. You do want to look at the individual pieces of what we've discussed. And one of the things that the question comes up, if CDI is in a chart and they capture a CC or an MCC, and it moves that record, and then coding also captures not only that CC or MCC, but they find others. Then how do you take credit for having moved that CC and MCC rate, or do you give that to the coders? And that's really something that you're, as a manager and a department, you would need to decide how you're going to evaluate that measure of success in particular. The book points out that that's something you need to decide. I personally, I'm not in a CC MCC state, but if CDI leaves a query, gets an improved SOI or ROM, or in some cases a CC or MCC, whatever happens down the road, I would still credit CDI with that movement. But really that is an individual program manager and facility determination, how you're going to claim that and capture that. Another way that you look at improvement by DRG is if the coder and the CDI agree. So if you have CDI staff that are concurrently reviewing the records and they're putting on a working DRG, and let's say, and there are reports that after coding that you can generate that say what percentage did your coder and CDI DRG agree, and if that's too low, then that's a flag to you that something's going on. And it can be many different things, but one thing is that perhaps your CDI did not understand using the encoder, or did not understand choosing primary diagnosis, how to come to the correct DRG, or they're looking at the chart, maybe it is a staffing issue, they're looking at the chart 24 to 48 hours into the admission, and then they're not able to come back and do any concurrent or follow-up reviews. And so their information is very early on in the stay, and many things are decided after that point, and many changes are made in documentation. So then if you have a high agree rate, then you know a couple of things. You know that your CDI are reviewing that record not only initially, but they're also able to get to their follow-up reviews. You know that they understand how to choose a principal diagnosis and a principal procedure. And you know that they know how to follow through on subsequent information. You also know, if you have a high agree rate between CDI and coder, that you have some good coders, because they are accurately interpreting what's written by the physician into codes, and your clinically educated staff, and they're all coming to the same conclusion. So this means that you have CDI staff who clearly understand coding guidelines, and you have coding staff who clearly understand some medical, they're interpreting that chart well. And it's not up to the coder to interpret the medical information, so I hesitate to say that, but they are reading that chart and they are accurately picking up on what they need to. And that's one thing that the coder and CDI agree report can tell you. Conversely, if you're far away, if you have a 20% agree rate, then you really need to drill down. Do you have a nurse who does not understand coding regs and guidelines and hierarchies, and how to choose a principal diagnosis and how to choose a right procedure, principal procedure? Or do you have some education on the coding side that needs to occur? So that's what that measure can tell you, and we call this the reconciliation process. So what we do is, after the patient is discharged and after the record has been coded, we'll run this report of coder and CDI agree rate. And if you have some good software, it'll come with details. Like it'll list the patient, the FIN number, or the account number, so that you can drill in if you need to see. And so what the nurse does, the CDI nurse does, is she'll look at her, mostly the disagrees. We tend to focus on the disagrees because if everyone agrees, then that's great. So she'll look at the ones where there's a disagree and she'll say, was this a coding guideline that I didn't know? Was this a hierarchy that I didn't understand? Was it a bundle I didn't understand? What was there subsequent information from the last time I looked at this record, be it diagnostic or procedural? Was it, so if the patient went, I looked at them on the 10th, they didn't go home till the 16th, and on the 14th, this was documented. So subsequent information after my last review. Or did this coder clearly not understand what the process was, what the diagnosis was, or what was going on, or what the procedure was? I find there are, obviously, just like nurses, there are coders with all levels of experience. So some are fabulous and well experienced, and some are newer and they have a little bit more to learn, just like nurses. So you really have to dig into what's going on with this case. Why did we disagree? And the reason why I like the reconciliation process is because it is a time of closing the loop on that patient, but it is the biggest time to highlight any educational needs, be it for the nurse or for the coder. It really brings those things to the forefront, and it helps you to know if you don't do the reconciliation process, if as a CDI nurse, or you just review the chart and you put your work in DRG and you never come back, how do you know if you were right or not? You're going to assume you were always right because that's we're right? So we would assume we're always right. So if you don't come back and close that loop and see what really happened with that patient, number one, you don't know if you were correct, or if there's something you need to learn, or if there's a coding rule that you need to acquaint yourself with. So I think the reconciliation, or if you have a coder who's maybe newer and needs to understand some of the clinical piece of it a little bit. So this process, I feel, is very crucial to the growth and continued success of any CDI program. And so one of the best things that you can do is have a good working relationship between the coding staff and the CDI staff, and open communication, that you can discuss charts without anybody feeling like they're being questioned or that they don't know, but it's a time for learning and growth. And I really emphasize with my coders and my CDI that we are a team. Clinical documentation improvement is a partnership. It's a partnership between the clinical documentation specialist, the coders, the providers who document in the chart. Everybody is needed to make this program a success. Everyone must do their part for you to realize all of the benefits that you can from this type of program. So the better you can communicate, the better you can foster a team environment, the more successful you will be with your CDI program. Productivity. This is a buzzword for CDI, and we've talked a lot about this. You have to prove yourself a lot of times in CDI, and one way you do that is by the numbers. How many charts do you look at every single day? How many new reviews? How many concurrent reviews? What percentage of the new admissions to the facility is your program able to review? And these things, these productivity numbers, depend on a few things. They depend on, first of all, the number of staff that you have. They depend on, are you reviewing electronically or still manually? Most people have electronic medical record now, but not everybody has great CDI software. There's some phenomenal software out there. 3M pretty much has that wrapped up, I think. I know there are a couple others, but 3M360 is a CDI and computer assisted software package that's kind of nice. And Modal has a really nice CDI package. It doesn't have the computer assisted software. It focuses more on the diagnostic and the documentation side. But just recently 3M acquired that M-Modal product, so I'm waiting to see what that marriage will bring about. But so there's some really great products out there, and if you have this software that's facilitating your CDI staff, it is going to help them see more charts in less time. Whereas if you're going individually, I have also worked where the CDI has to go into the medical record, review the record, then they have to go into the encoder and enter all their data and come up with a working DRG, and then they take all of that information to yet a third system and they enter it into their CDI tracking. And so they've got 3 windows open and they're toggling between all 3. These types of things do tend to slow you down just a little bit. So there is some software that helps you be much faster, and the M-Modal software actually can review the charts overnight while you're at off, and in the morning when you come in, it already, based on your caseload and your assignments for the day of charts you need to look at, it's already suggesting these are the queries or these are the gaps. It's identifying those gaps in documentation and saying you might want to look at these gaps. You might want to focus on these charts. So certainly software that can focus you in that way is going to increase your productivity a fair amount, right? So the software does make a big difference. The other thing that makes a big difference is how long you've been doing CDI. You can't expect someone who's fairly new to have the same numbers as someone who's been doing this for years. And it takes time. I know our textbook says it takes 6 months, but I will tell you that when I train someone, I don't expect their productivity to match the peers that have been there longer. I would give someone up to a year before I would really have that expectation. It just takes that much time. There's so much to absorb and so many things to acclimate to. But anyway, 6 months to a year. And so if you have a bunch of staff who are newer than that, you're going to be slower. You're going to see less admissions. And your productivity expectations need to be adjusted based on the years of experience. And then there's the complexity of cases. It depends the patient populations that you cover. But if you're covering, at our facility that I'm at currently, we try to cover every payer source. We do not cover every unit, but every payer source. And that is different for us. It used to be we covered certain payer sources. I know a lot of programs that do not go into mental health units, that do not go into newborn nursery or even maternity, labor and delivery. There are just some clinical areas and service lines that historically CDI has not really been involved in. But the more that CDI moves to a quality focus, I am seeing more and more programs begin to cover even those units. So having said that, we get back to the complexity of cases. If you're looking in the OB unit, and you might have a huge population there. We have some really active obstetric departments, but those patients come in and go out every 2 to 4 days, depending on vaginal or C-section. And there are a couple of DRGs, and you'll just use them over and over and over. And you should really be able to whip through those charts very quickly. Just look at any abnormalities, just really quickly whip through and see if there's anywhere you can move the severity of illness at all or capture any CC or MCC, and then you slap that 519 on there or whatever it is and you move on. So very quick. Another very quick area that we actually do cover is our joint. We have a joint unit, hips and knees and etc. Those are very quick. most of those patients come in, they may have some secondary diagnoses, but they come with a thorough H&P, and all of those diagnoses are compensated and stable, and you'll just move through those reviews so quickly, and you'll put that hip or knee DRG on there, and you're on your way. Then you have other units like ICU, CCU, trauma units. These are going to be very complex cases, and they're going to take a long time to review. You want to make sure that you have clearly established what is your principal diagnosis. You want to capture all of your CCs and MCCs. You want your risk of mortality to be optimized. You want your severity of illness to be optimized. Those are just going to take a little longer to review. And so that is something as a CDI manager, when you're looking at assignments and and you're looking at productivity and you're saying this person is more productive as opposed to this person, the patient population really does impact that whole picture. And another way that we look at productivity and we look at effectiveness and impact are by our queries. So the big overreaching metric is our query rate, right? And I think the industry is still saying somewhere between 30 and 35%, even up to 40% is a good query rate for a facility. So what does that really tell you? That tells you that on 40% of the charts, or whatever your query rate is, but 30 to 40% of the charts that your CDI pick up, they are leaving a query or a question to fill a gap in documentation 30 to 40% of the time, right? And that's what that tells you. And that is all that that metric tells you. If you want more information, you have to drill down into the types of queries that are being left. Do they move the DRG? Do they change the DRG? Do they move the SOI? Do they move the risk of mortality? Are they answered or are they not answered? Are they answered before coding or after coding? Are your coders picking up on the concurrent CDI queries? Are they paying attention to them and coding appropriately based on the response to those queries? These are the questions that really, and the answers to these questions is really what tells you, do you have a successful query system, right? So that big metric is good, but it doesn't give you specific data on, let's say, the type of query that you're leaving, which will then tell you the type of education that you need to do. And that can be drilled down with your software by, could be provider, could be by service line. So you really need to know the types of queries, the impact they're having, how often are the physicians responding, that type of thing. And then, so you do audits, right? We talked about that last week, I think, and you do audits, and you want to make sure that queries are not being missed. So one way you do that is you look at the record and you say, yes, the CDI did ask this query, but I've had CDI ask queries. Maybe it's a query about chronic kidney disease staging, a specificity query. Is that a legitimate query? Yeah, you can ask that question. Specificity is always good. But if you've missed the acute renal failure, or if you've missed the acute respiratory failure in your quest for getting the stage of the chronic kidney disease, then you really have not evaluated that chart appropriately, even though you have asked a query. So as a manager, again, that big query rate can look great for your facility. It does not ensure success. It's just a metric to say you are querying that population of charts. But you really need to know what questions your staff are asking. Are they asking the right questions? Are they asking the most important questions? You know, sometimes a chart, if it just comes to specificity, you could ask 6 questions, but you don't want to overload the physician with that when there's a really impactful question that you could ask that also really impacts the quality of that patient's record, excuse me, for ongoing consistency in their care as well. So, and you can track these, excuse me, queries can be tracked by provider, by CDI who leave them. They can be tracked by service line, by type of query, all types of ways you can slice and dice your query data to find the information that you need on how successful are your queries, how impactful are they. And as we talked about, the physician response rate is very important. Not only first of all, is he responding? Yes or no? Is he engaged in your program? That's what that tells you, yes or no. Is he engaged in understanding of your CDI program? Then, does he agree? Yes or no? And what does that tell you? So if he never agrees, then I would say he's not engaged, because he's just picking the easy way out. I don't agree, right? Or even if he doesn't respond, that's what he's doing as well. I don't want to play in your sandbox. I don't want to know. If he always agrees, you would think that would be a great metric, right? So, but still, I would evaluate those charts. And does he always agree because that's the easiest way out? Does he always agree because your CDIs always leave great queries, well worded and well validated with clinical documentation? That would be optimal, but you do need to validate that periodically as well. So you just look at the different things surrounding the physician response and try to evaluate, is this because we have a great program? Is it because we need to more heavily market our program, so to speak? We need to get out there. What does the physician response rate really tell us? Other areas that queries can impact are core measures. I work closely with like the CHF clinic, and they'll say, this patient really didn't have CHF. It was not a CHF exacerbation. They came in for something else. And if you've done any work around CHF, especially the coders, you will know sometimes there are things that kick to CHF that the core measures people don't want to admit, but it is due to coding nuance. But you also can determine if there are other things that could be principal diagnosis that would not leave you in those DRGs that impact core measures. So I think of CHF and MI. Sometimes it's, rule out MI, and you can look at the clinical data and think it really was ruled out, but nobody really said it. So it got coded, but it didn't meet core measures because the discharge treatment wasn't really for an MI, because it wasn't really ruled in. That's the kind of scenario that comes with core measures. And then you can go back and clarify, was this, and we do that, right? We clarify rule outs before the patient's discharged. Was this diagnosis ruled in or ruled out? Because that makes a difference. MHACs or PPCs, potentially preventable complications, can be really impacted by the documentation of presence on admission. Also the validation, we validate a lot of those diagnoses. Like a lot of times patients will come in shortness of breath and a physician will write acute respiratory failure, but the treatment and the symptoms and the signs really don't validate. Maybe the patient just had respiratory insufficiency. So we validate those diagnoses to make sure, was this really a respiratory failure? Do we really need to incur that PPC? Or did this patient have a very transient respiratory insufficiency? So that's another area. Denials. A lot of times patients come in and they're given the diagnosis of, let's say, sepsis, and they really don't meet the criteria for sepsis. In that case, will be denied. And there again, we do a lot of diagnosis validation based on signs and symptoms and predetermined definitions. It'll depend on your facility, but our facility has a definition for what is acute renal failure, what is acute respiratory failure. Of course, we use the sepsis definition, UTI even we have defined. So we have about 9 of them. I'm not remembering all of them right off, but and so what happens then when the CDI are in the chart and they see this diagnosis and they do not see the clinical signs and symptoms to support such a diagnosis, then they will validate that with the physician, and they will literally say, you have documented acute renal failure. This is the patient's BUN and creatinine. This does not meet the hospital-defined definition of acute renal failure. Please consider whatever, right? And so then that helps to eliminate getting an inflated coding picture, I'll say it that way, right? And of course, whatever is your principal diagnosis, and then whatever DRG you fall in, this is going to impact the length of stay that's expected for the patient. So I'll go back to my pneumonia. If it's a simple pneumonia, and I do not know the length of stays by memory, but if it's a simple pneumonia, I'm thinking probably 3 days. And then if it's a complex pneumonia, maybe 4 or 5 days are allowed for that DRG. And so based on the documentation that you clarify and the movement in the DRG, you are impacting the length of stay that's expected for that patient. And that's really important when you have patients who aren't ready to go home on day 2 based on a lesser DRG, whereas if you'd moved it to this other DRG and they're ready to go by day 4, then they're right on target. So I would say, whenever possible, to have success with your program, collaborate with anyone you can in your organization. CDI should collaborate, first of all, heavily with coding, but certainly with quality, with case management, with the appeals staff, with the medical staff, with the nursing staff. There isn't anybody in the organization that could reach out to me that I could think of and I could say, I just have nothing to do with what you're doing, right? Because everybody documents, and all of that documentation has the potential to be used by you as a CDI to build an accurate picture of what's going on with the patient. And the more you collaborate with other entities within the organization, your value will grow, your, I don't want to say importance, but how much people rely on you, how much you're worth. You're really your worth to the organization. You have to build that as a team. Build that worth. Everyone knows the worth of nurses at the bedside. Everyone knows the worth of housekeeping. I mean, where would we be without them? Everyone knows the worth of lab. Not everyone knows the worth of CDI. And that is up to the CDI team to build that knowledge and to build that team so that everyone sees it. And that is an ongoing process, right? So how valuable your facility finds you and your CDI department depends on, first of all, why did they develop a CDI department? What are the goals for the department? What are the KPIs? How well are you meeting those goals? How well do you perform in comparison to benchmarking? But also how well you integrate yourself into the daily workings of everything that impacts the patient's chart. Again, into the core measures, into the quality, into the reimbursement, into the length of stay, into appropriate DRGs and appropriate documentation and the best diagnosis for the patient, and just all those things that you can impact. This is going to say how valuable you are to your facility, how much you can help other people, how much you can help them understand how to optimize their documentation. And all of this is done in the setting of providing the patient with the most accurate, the most complete and precise medical record, so that when they seek, that everyone involved in their care in this current episode knows what's going on and knows what's expected and what's needed, but also down the road when they seek subsequent medical care, it is clearly stated in their record everything that happened to them, everything that worked for them, everything that didn't work for them, everything that was ruled in and ruled out, so that the next provider that touches their record has such a clear idea of where they're at medically that that person can pick up and move forward without any re-investigation or stumbling at all. And that's the goal of CDI. That's how you determine what is a successful CDI program, right? And success is hinged on keeping up with medical practice and coding practice and keeping current in your education and keeping your providers current in their education. There isn't anything status quo in CDI. Nothing stays the same. Once you establish a program, you're just beginning. You're just beginning. If you want that program to have ongoing success, you must constantly and consistently evaluate, develop performance improvement measures, implement those measures, reevaluate, and that cycle just goes on and on and on. And you really have to never stop that if you want to ensure the success of your CDI program. Thanks. That's the end. Have a great week.